Assalamualaikum warahmatullahi wabarakatuh. Hello, ladies and gentlemen. In this time, I will presentation about management COVID-19 case in the community setting in Santa Lucia. Before I will presentation, I will introduce myself. My name is Muhammad Yaser Alintako, NPM H1A021042 from Department Medical Science. There is a several outline. First, COVID-19 situation update. Second, communication and coordination. Third, clinical assessment and management. Fourth, monitoring and evaluation of patient. And the last, summary. Here, there is a COVID-19 situation update in March 15, 2021. There is a 161 active cases, to critical care 55 death, 1.4% case fatality rate, 4,051 total confirmed, and 33,886 total test PCR. So we enter the developed community COVID-19 plan. First, stabilize for COVID-19 community medical teams with targeted training. There is physician, full-time or seasonal district medical officers, and nurse aides. Second, non-medical super personnel. There is environmental health officers, which is home decontamination, and next, Royal Science Lucia Police for Office Force officers, and third, Science Lucia Fire Service personnel, and four, counselor, five, social support family members, and the last is scope for addition of volunteer or designated person on team to assist with social support. Next is communication and coordination. Capturing of positive COVID-19 patient, there is a three. The first is 5 respiratory clinics on island. Second, hospital. Third, private clinics. Positive result issues to epidemiology unit. Epidemiology unit issues list of patients for community management. Next is communication and coordination. There is a first, establish intra-sectorial communication channels with chain of command. And the second, referral pathway to respiratory hospital. And the third, hospital on-call hospital physician schedules share with clinical team through senior medical officer and principal nursing officer. And the fourth, community physician liaise with physician on call at respiratory hospital. The newly diagnosed patients with COVID-19 are referred to public health facilities or respiratory hospital depending on severity. And In the intersectoral communication, there is first through a specific chain of command from the lead physician, home monitoring team, or the surveillance officer or national epidemiologist who informs the fire chief to activate the designated EMA's COVID-19 response team to effect transfer of positive or suspected patient to or from hospital. The transfers between public health facilities and to hospitals, and transfer of stable cases to community public health facility. And the facilities. First, level 1, home. Home assessment personnel. Home. Home assessment personnel on short-term contact. Non-medical personnel. For level 2, public health facility, hotels and smaller facilities. Level 3 is respiratory hospitals. Next is classification of patient. Home or public health facility isolation. There is a asymptomatic and mild signs and symptoms. In the mild signs and symptoms, there is a sporadic cough, normal oxygen saturation, there is 95% or greater on room air, and hemodynamically stable, coryza, sore throat, myalgia or arthalgia, anosmia, ageusia, caplia, and no uncontrolled comorbidities. In the hospital isolation or management. First, all high risk and clinically moderate to severe COVID-19 positive cases must be hospitalized. And the second, signs and symptoms include there is a deranged fetal, SP02 less than 95% on room air, and shortness of breath. Home monitoring. COVID-19 home monitoring consists of well-structured system layout. There is a first database accessible to the home monitoring team or AP unit. The second, public health facilities connected to health management information system. Third, real-time interaction with database. And fourth, information inputted is constantly monitored by physician. And the last is use of biointelligence, biobuttons for monitoring patient vitals remotely being rolled out. Structure of home monitoring team. The first case is positive case received from epidemiological department. First, and the next, first point of contact by community health aides. And the next, health aide continues to monitor patient daily. And the next, medical doctor and nurse conduct home visits. And the last is patient is discharged by the medical doctor. The next is intervention. There is a first, in community home isolation, our focus is early intervention. The second, home visits are scheduled based on severity. The third, virtual visits via video interaction are utilized where a home visit may not be possible. For patients are also encouraged to call at any time as our medical team is readily available 24 hours a day. 5. Based on patient assessment, there is a treatment is given for mild systems, and patients with moderate to severe symptoms are referred to the respiratory hospital for further care. The treatment in community include the first is symptomatic treatment for mild symptoms. There is a paracetamol as analgesia or antiseptic, and a deep breathing exercise, example blowing balloons, and increase of fluid intake orally. And the second is ensuring that patients with underlying medical condition have all their regular medication at hand. And in this summary, we got a staffing limitation by supplemented by Cuban Medical Brigade and patient compliance. There is other hands to public health protocols and other hands to treatment. And the next is recoverage limitation. And the next is assessing patient during the night challenging, especially for female physician and nurse. And the last is video call with referral to respiratory hospital. So there is the summary if we got a COVID-19. That is my presentation. Thank you for attention. Assalamualaikum warahmatullahi wabarakatuh.